20-year-old woman with history of an eating disorder comes in with painful vomiting where she vomits blood over the last week. The patient's BMI is 19, and on exam, calluses are seen on her hands, and labs show hypokalemia and metabolic alkalosis. What is most likely to be present? A full thickness esophageal rupture. B. Lacerations in the mucosa at the junction of the stomach and esophagus. C. Visible webs in the esophagus. Or D. Venous dilation in the submucosa. So I'll let you answer the question, and then I'll explain in 5 seconds. Okay, so the answer is going to be B. Lacerations in the mucosa at the junction of the stomach and the esophagus. So for this question, essentially this is describing Mallory-Weiss syndrome. So this is where you have repeated vomiting in a patient with history of alcoholism or bulimia. And so essentially in this patient, it's a 20-year-old, so both could be possible. So if you're thinking about a 20-year-old, you're thinking about a college student, so there's a risk there of getting an alcohol disorder, or in this case, they're hinting more at a eating disorder. So that's why they're telling you the BMI, because they want you to differentiate between anorexia and bulimia. Because in anorexia, it's going to be a BMI of less than 18.5. But in this case, the BMI is 19. So that means that it's hinting more towards bulimia. And the second thing is going to be the fact that it's repeated vomiting. So anorexia, they can have that type of problem, but bulimia is known for that, where they're trying to induce vomiting. And that's why they're trying to show you that with the exam finding of calluses on their hands. So essentially what's happening is when they're trying to induce vomiting, the dorsal hand calluses that you see are called Russell sign, and it's when the knuckles scrape against the teeth. And so that creates these calluses. But going on to the other problems that we saw in the labs, so what we will see is decreased acid, because if you think about it, well, we have hydrochloric acid in our stomach to normally digest food, but if you're vomiting all this acid out, well, your body's going to be without acid, right? And so it's going to become more basic. And so it's going to be metabolic alkalosis after you've vomited a bunch of times. The next thing is hypokalemia. So in this case, how that works is you're losing a lot of volume and you're going to become dehydrated if you're vomiting this much. And so that's going to activate the RAS system, so the renin angiotensin aldosterone system, is this is a way for you to boost fluid when your volume deplete. So how this system works is it's going to activate aldosterone. Aldosterone is going to create ENaC channels, so sodium channels in your kidney, and that's going to increase sodium absorption, and that's going to cause potassium to be excreted. So you're going to retain sodium, so that way water follows the sodium and you try to retain as much volume as possible. But in exchange, you're going to dump out potassium, and so that's what's going to cause the hypokalemia. And so moving on, we have the other options. So for Boerhaave syndrome, it's going to relate to the full thickness esophageal rupture for A. And so looking at that a little bit more, so we have the definition of it, which is just the perforation of esophagus. And so it's pretty rare. It's only around 3 people per 1 million that will have this condition, but it's something to think about. And so the patient will usually have retrosternal chest pain, and then after a few hours, they can have crepitus on palpation of the chest wall, because since you're perforating the esophagus, air can come into it, and now when you press on the chest wall, you'll feel crepitus, which is it's when you feel air bubbles underneath your hand when you're palpating on that part of the body. And so other lab findings will be leukocytosis, which is just an acute increase in white blood cells, which makes sense because now since you have perforation of the esophagus, now you're going to have to respond to that. And and bacteria can get in where it normally couldn't. And next, how to diagnose it. We're going to either do a CT or contrast esophagram. So we're just looking for that perforation. And then first you try conservative therapy, but really you do need to get a surgical consult, because if they rapidly decline, even with conservative therapy, you will need to go in and repair that. Now, talking about the other answer choices, we have venous dilation in the submucosa. So this is typically going to be a cirrhotic patient. So when you have cirrhosis, you have portal hypertension. So essentially, because the liver is getting damaged, it's going to create a lot of pressure for the vessels there. And so that pressure is going to end up as the portal hypertension you see. And so so essentially, if you have a traffic jam, it's going to create a congestion behind it. And that's kind of what happens here as well. It's going to create a congestion, and then that's going to go back up to the esophageal vessels. And so that's going to engorge them and make them more prone to break. And then since it's in the esophagus, you're going to end up with that blood into the lumen, and then that patient can throw that up. And so that's what you would consider if, for example, this patient had a history of cirrhosis. So the last answer choice is going to be Plumer-Vincent syndrome. So essentially the three things you have to look out for, the triad, it is dysphagia, which is just trouble swallowing, iron deficiency anemia, and then esophageal webs. So that's the triad that you would want to look for. If you were looking for a patient that had esophageal webs, just check their labs to see if they're iron deficient and see if in their history they said anything about having trouble eating or swallowing. And so going back up, for this problem, you essentially had to recognize the clinical picture of Mallory-Weiss syndrome, which is where you typically have a young person come in with either a history of alcoholism, or you have a eating disorder in someone a little bit younger. Maybe if it was a 40-year-old with alcoholism, you can start thinking about constant and repeated vomiting, and then both of those conditions would lead you to think about Mallory-Weiss syndrome. But then this was also hinting at it more being a eating disorder by showing that the BMI was normal because it's within the normal range. And then you have the labs showing hypokalemia, like I explained, because you're activating the RAS system, and metabolic alkalosis because you're losing all of the acid in your stomach. And so I hope that helped, and thanks for watching.